Way back in 1897, it was also recognized that smoking constituted a very inordinate drain on the pocketbook. The amount of money spent annually in the United States is amazing. As much as for bread, twice as much as for boots and shoes, twice as much as for cotton goods, 3 times as much for woolen goods, 4 times as much as for public education, 40 times as much as the minister's salaries, and 120 times as much as for home and foreign missions. Great Britain and Canada spend a similar proportion on tobacco. And of course, this explains why people seek sources of tobacco which reflect lower prices, and thus the contraband issue is an issue that affects all of us, and it impairs our ability to help smokers, and also undercuts many of the public policy initiatives which have been put into place, which have successfully reduced smoking rates in other settings. On the manners, well, the tobacco habit is unmannerly, to say the least. The way men will blow their smoke into the face of others is exasperating. They regard it as their right to do as they please, but we must remember that in an ideal civilization, each man in stating his privileges will consider and respect the rights of others. And if you think about that, it has obvious relevance to the whole issue of secondhand smoke and public policies around secondhand smoke, but also we understand that secondhand smoke is a substantial public health issue in and of itself in the home setting. And here we see in 1897, in the home, the air is poisoned and the health of the other members of the family is affected. A certain lady whose husband was a heavy smoker was constantly delicate. On the doctor's advice, the husband ceased to smoke in the home and his wife began to improve and was soon quite well. And clearly, our understanding of the importance of protecting others from secondhand smoke is now reflected in some of the public health campaigns and public health initiatives which we see reflected in our society. One of the saddest phases of this tobacco habit is that innocent children are born into this world with a tobacco appetite and with weakened constitutions. They will have to make a superhuman effort to control that appetite. And of course, now we know that exposure to nicotine in utero can cause changes in underlying neurophysiology affecting the hardwiring, which makes it much more likely that a child born of a mother who smoked during her pregnancy will much more likely to become a smoker as an adult, or as an adolescent, I should say. And we also see that in the obstetrical, neonatal, and indeed pediatric communities, that once again there is a growing recognition that systematic approaches to the identification and treatment of smokers using pharmacotherapy as appropriate constitute what in the United Kingdom are called beacon services, the exemplary kinds of programs providing the best quality care in this setting as in others.
So really what we're all about at the Ottawa model is really developing systematic approaches to ensure that cessation efforts are coordinated, systematized, and integrated into all professional health settings. And there's been tremendous growth in these areas over the last years, led by armies of facilitators that we have working on both the primary care side and the hospital side from our institution, but also from the work of many other organizations in this room as well.
And you're going to hear from many of those individuals from those organizations. Our colleagues at CAMH have provided exemplary leadership in terms of training large numbers of health professionals across a variety of disciplines in the principles of tobacco treatment and the development and introduction of cessation programs.
And importantly, there are many different settings that these kind of interventions can take place. And this slide just emphasizes how primary care is a place where many more smokers can be identified necessarily than in acute care settings, although across the whole spectrum there's a need for systematic approaches. So in fact what we find amongst the medical profession is that we're actually very good at actually providing advice to people to quit smoking, but we're abysmal at actually providing real assistance to those individuals. So rates of advising are very high, 70 to 80%. Assistance actually falls to around 30%.
And it's quite clear that given the changing environment, that the reality is that the overwhelming majority of smokers know why they shouldn't smoke. A substantial majority of smokers want to be non-smokers. And a significant proportion will make personal quit attempts each year, most of which are destined to fail. And I think it's very important that we reconfigure our approaches to our smoking patients. recognizing that notwithstanding our default to education, the smokers don't require more information, whether it's delivered, no matter how imaginatively or innovatively it's delivered. Fridge magnets and interactive CD-ROMs, etc., are all very useful but have profound limitations to a population of smokers who already know why they shouldn't smoke and don't want to be smokers. They don't need more information or lectures, they need assistance. And one of the purposes of this conference is to ensure that we are a rising tide, if you will, that raises all boats, so that we recognize how in our own particular settings and in settings that may not be represented here, we can provide 21st century evidence-based best practice smoking cessation services to that population. And I think there are two fundamental principles that should guide us in this respect. We should treat smoking cessation in exactly the same way we manage a whole array of other clinical conditions. And because I come from the Heart Institute, I generally talk about hypertension and hyperlipidemia. Our approach to the management of hypertension is not to say hypertension is really important. It causes very many nasty things. Let me take your blood pressure. I see you're hypertensive. Why don't you go away and think seriously about making a hypertension control attempt at some point? We would think it absurd. Way back in the 40s and the 50s, before we had diuretics, that's all we could offer. But that situation has changed dramatically. And I would argue that now it's inappropriate to say, I see you're a smoker, nasty things happen to smokers. Why don't you go away and think about when you're going to be ready and willing and prepared to take a smoking cessation attempt, as opposed to, we are ready and prepared to help you with smoking cessation if you'd like to be a part of the process right now. And of course, the management of smoking cessation pharmacotherapy, which is central in the 21st century to the management of smoking cessation, should be approached, in my view, in exactly the same way we manage any other medications. We identify a problem, we make a diagnosis, we make a prescription, and we manage and titrate that prescription. Sometimes we combine that prescription with other medications, and we use those medications for as long as is necessary in order to achieve the desired end. And so I think you're recognizing that the fixed dose paradigm has profound limitations. Some of you may have heard me describe that as Presbyterian light. I'm going to give you some help, not too much, just for a few weeks, because you should be able to do this all on your own, which is an improvement over the Presbyterian approach, which is you should be able to do this. Are you listening to me? When you can be a better person, stop something, get more organized? Because obviously, that's all it takes now. Are you listening to me? Charlie stopped smoking 3 months, never sit in the front row. Charlie stopped smoking 3 years ago. He smoked 40 cigarettes a day for 25 years a year. Everybody should be able to do it. Why can't you?
So really what this conference is all about is how do we transform practices amongst our clinical colleagues. And that comes from changing institutional practices, changing professional behaviors, and if we can do that successfully, then we can enhance patient care and make it much more likely that people will be able to successfully give up smoking.
In fact, I think it was you, Bob, that said in response to the rhetorical question, what can we do to help patients change their behaviors? I think your response was,
they have to change professional behaviors, change the behaviors of healthcare professionals. That sounds like something I would say. Speaking of something that I would say, go ahead.
I'm a little taken aback that anything with such clarity and insight is something that you would normally say. But the other important thing to consider is that the environment has changed.